I have a half an hour to kind of kick things off and set the stage for some of the lectures that my staff and I will be doing over the course of today. But I'm tempted just to use the half hour to talk about Mike Baxter. Mike is just such a collaborative, wonderful person, and we are so honored and privileged not only to be here today, but to be with him and co-sponsor our Addiction Medicine Fellowship. Mike's right. We were the first community-based treatment facility, community-based health system to be granted such an honor, and we remain one of the only that exists today. There's only 46 fellowships in the country. There needs to be a lot more, and we're just very happy to be at the table early on, and it was Mike's vision and his acceptance of this idea that made it all possible. So today I've been asked to talk to you about the substance abuse epidemic and the essential role of the family physician. I have no relevant or even irrelevant financial relationships with any commercial interests. When I decided to conceptualize this talk, I really looked at other talks that I had done. I've done a lot of grand rounds at different health systems around the opioid epidemic. And one of the talks that I've created is the opioid use disorder epidemic, what happened, where we are now, and where do we need to go. And that's really what this talk is all about, but focused to family medicine physicians. I'm an internist, first and foremost, so I'm a primary care doctor and always will be, despite going back and training in other entities. I actually have 3 board certifications, so I don't do anything but maintenance of certification. That's all I have time to do. But when you want to change something like an epidemic that we're facing, where we're losing way too many young, healthy people, we really have to look back and figure out, how did this happen? And we have to own our part in all of this. And I look at it as good intentions with unintended consequences. When I started in internal medicine back in the early 1990s, there was a focus on pain, as there should be a focus on pain. And that focus kind of evolved over time, and different regulatory agencies got involved. And what happened was that early on in the 90s, the VA decided to codify pain as the 5th vital sign. And the Joint Commission took that and incorporated it into their standard, which came about in 2001. And that standard was all about identification of pain, qualification of pain, quantification of pain, and treatment of pain. And we were held accountable in the acute setting, outpatient setting, subacute setting. It didn't matter. No matter what the patient was in for, we had to ask about pain. And we had to qualify and quantify it and then treat it adequately. And that's all well and good, but again, good intentions with unintended consequences, because we haven't understood how to treat chronic pain. And I'm going to talk a little bit about that a little later in the talk. But we've been using acute and subacute tenets to treat chronic pain, and that's what we did. So if someone has pain, significant pain, we prescribed pain medication. And what happened is the number of prescriptions over time grew. And coincidentally, back in 1996, OxyContin came to market. And OxyContin very quickly rode this wave to become the #1 narcotic in the world in 2001. So it came out in 1996, 2001. It was the #1 narcotic in the world. And I remember when reps would come into our office, internal medicine office, and talk to us about the decreased addiction potential of OxyContin because of the unique delivery system, slow uptake, long acting, all meant to reduce addiction. And it made a whole lot of sense until street pharmacists got a hold of it and changed the delivery system. And now they got immediate release at much higher dosages, and we all know where that has led us. So the Hospital Consumer Survey and Healthcare Providers and Systems, HCAHPS, decided to put 3 pain questions on their survey in 2006. Initially, it was optional, and then it became mandatory with the Affordable Care Act. And that's important because reimbursement through CMS was tied to those answers. So our patients dictated our reimbursement depending on how they answered those 3 pain questions. So now you have this real incentive to quantify, qualify pain, and treat it. And what we did is we prescribed. We prescribed, and we prescribed, and we prescribed. And it got us into an epidemic in the end. So good intentions, unintended consequences. So looking at epidemiologic data, the NESARC-3 study came out recently, and it looked at 2002 as compared to 2013, and specifically at opioid exposure, opioid use. Opioid use in 2002 was 1.8%. That went up over 2 times in 2013 to 4.1%. So more than doubled in that period of time. So those prescriptions that we kept writing, the identification of pain, the prescribing of opioid analgesics, exposed more and more, millions and millions more people to opioid analgesics. That translated to, in 2013, 10 million adults that were exposed to opioids in that year, 2013. They also looked at non-medical use, which is changing the delivery system, so from PO to intranasal, for example, or taking more than you're supposed to, or taking it more frequently than you're supposed to. And that changed as well. In 2002, the lifetime prevalence of non-medical use of opioids was 4.7%. In 2013, that went up to 11%. So that too more than doubled. And they also were able to identify specific non-medical prescription opioid use disorders. And what they found is that 1% met that criteria, and that's 2 million people. And I don't have to tell you about the opioid use disorder epidemic. 65,000 people died in 2014 from drug overdoses. A majority of them, 2/3, were opioids. And I'll talk a little bit more about that in a second. But right now, drug overdose is the leading cause of death under 50. So we are in a true epidemic. We are losing young, healthy people in droves. And our treatment facility is representative of that because we have had an amazing increase in opioid use disorder in our treatment facility at all ages, but mainly in the young adult population. So this is just a graph of the increase in prescriptions that have occurred since 1991 to 2013. And you can see there is a linear increase in those prescriptions. So if you look at just hydrocodone and oxycodone, there's just a precipitous rise in prescriptions that that peaked in 2011, started to drift down, and we are starting to make some positive changes with the PDMP that's across the country. The PDMP finally got to Pennsylvania. We were one of the last to have it. Happy that it's here, and it has made a big difference across the country. We're holding physicians responsible if they are outside the norm of prescribing. So if they're irresponsibly prescribing opioid analgesics, they're offered re-education by health systems. Also, the board sometimes gets involved, the DEA as well. So re-education first, because again, good intentions, unintended consequences. If that's not enough, then there's bigger consequences. So we are making a difference. That's drifting down little by little, not as quickly as we would like, but it's happening. So who's writing these prescriptions? We are, and we really have to shift the paradigm to medical schools. We have to do better in educating young minds at an early stage about addiction medicine and about responsible opioid prescribing. That's happening. Dr. Rachel Levine, who is the Physician General of Pennsylvania, someone that I've had the pleasure of working with, we all have at Caron on many different projects. she convened all the deans of all the medical schools in the Commonwealth and demanded, really, that curricula changes to focus in on addiction medicine and also focus in on responsible prescribing of opioids. And that is slowly but surely happening. And many great things to say about Dr. Levine. She is a forward thinker. So why is this important? This is important because as we write more and more and more of these prescriptions, more and more people are dying specifically from these medications. So you can see that there has been a precipitous rise in overdose deaths secondary to the oral opioid analgesics that we prescribe. And that number is not going down, it's going up. And unfortunately, despite the gains we've made in prescribing, there's still so many medications out there on the street that we haven't seen a decrease in the number of deaths, that the number of deaths continue to go up. So in 2014, I told you it was 65,000. That number has gone up in subsequent years. And, we're hoping at some point in time that we'll start to see a decrease. But estimates now are that we're going to see 20% increase before we ever start to see a flattening out and then decrease. So this epidemic is far from over. So this graph is looking at heroin deaths. And the connection is significant. So what we've done, again, good intentions, unintended consequences, is we have exposed the generation to heroin. And the way that works is that when we prescribe opioid analgesics to patients and continue to prescribe them, they begin to seek them for other things other than pain. So a typical case at Caron is a young person who had their wisdom teeth removed or had an orthopedic athletic injury. They get 60 Percocet, and the pain that they had went away in a couple of days, but they continue to take the Percocet because it helped in other areas. So other pain, like psychological pain, emotional distress, got better with it. So they come in, they feign pain, and they get another prescription. And then we say, that's it. We can't do that. We cannot write any more prescriptions. So they get cut off appropriately. And then what they do is they seek opioids through the medicine cabinet of friends and family. It's the number one place that they go initially. And then once they exhaust those resources, then they begin to buy opioid analgesics from the street. And that's an expensive proposition. It's roughly about $1 per milligram, and as tolerance goes up, they outstrip their financial resources fairly quickly. And then that dealer who's selling them those pills happens to have heroin. And that dealer, that very nice dealer, says, hey, I got a product for you. I can stretch your money. And heroin is extremely affordable. It's very cheap. And that's what they do. They switch them over to heroin, and then they start using that intranasally first because the purity has gone up in heroin. Here in Berks County, the purity is 51%. So that was in the single digits back in the 70s, and all you can do was use it intravenously. But now you can use it intranasally, avoiding the stigma of intravenous drug use. So intranasally they begin. They start to use more and more and more, and then they eventually convert to intravenous. And then they start on a horrible trajectory, and they go from a few bags a day to a couple bundles a day. And that habit is, could be very deadly. And the reason that there's so many opioid deaths out there, heroin deaths, I should say, is that synthetic opioids have made its way into the supply chain of heroin. And they are extremely potent, and they have an LD50 that's very low, and eventually they have respiratory depression, and then they unfortunately die of an overdose. And the unique thing that happens, it's counterintuitive, but dealers who have a spate of deaths from selling this type of heroin with fentanyl in it end up having a huge boon because of those deaths. So kids will come from Philadelphia and the surrounding collar counties just to get the good stuff. They stamp it with skull and crossbones, Philip Seymour Hoffman's picture, Prince's picture because they both died of fentanyl overdoses. And there's an uptick in the dealer's business. And so it's counterintuitive, but that's what's happening out there. And you can see that there's a precipitous rise in heroin deaths. Nope. So it just keeps going up and up. And as we get better at controlling prescription opioids, we're going to see an ever-increasing amount of heroin use and heroin deaths as a result of that. So this is just looking at the two together, and you can see that there is a linear increase in overdose deaths attributable to both heroin and prescription opioids. And what's going to happen is the blue line will get bigger and the yellow line will get smaller over time, but the amount of deaths will increase over time. And this is just looking at it from a different way, because it's hard to see that our efforts are working when it comes to prescription opioid deaths, but they are. So when you look at it as deaths per 100,000 population, we can see a leveling off of the commonly prescribed opioid analgesic deaths. But you can see a precipitous rise in heroin and synthetic opioid deaths. And that trend is very, very concerning because these are deadly medications. When you think about fentanyl, which is 50 times morphine, heroin's 10 times morphine, carfentanyl's 10,000 times morphine. So you have these incredibly potent synthetic opioids that the unsuspecting heroin addict is taking into their system, and they have no chance. If they get carfentanil, they're not going to make it. They're going to have a respiratory depression and they're going to die. Our nurses do the searches now, and we had to gear them up because at times we'll find residue from our patients that come in, and that residue, if it contains carfentanil, can kill our nurses. And it's happened before. Police officers have had to be resuscitated. 2 counselors in this area perished from searches. Carfentanil was found. So it's a big deal. So we have to be cognizant of what's happening on the streets, and we have to understand that we cannot allow this progression to go any further because we're getting into dangerous synthetic opioids that have real potential for overdose deaths. So opioid use disorder epidemic, someone's dying every 19 minutes. And opioid pain relievers are responsible for more overdose deaths than cocaine and heroin. That's changing now. Heroin is catching up quickly, but still, opioid analgesics are still the number one reason people die from opioid overdoses. And this is just a graph showing the causal relationship of opioid analgesics and heroin. So you could see back in 2002 and 2004, that of the heroin-addicted patients that were in this study, that 21% had an antecedent exposure to prescription opioids. And then when you fast forward to 2011, 2013, it's up to 45%. There was a study from NYU, Monitoring the Future, looking at heroin addicts. 65,000 were interviewed for the study. 77.2% had antecedent oral opioid exposure before converting to heroin. So that's how this generation got exposed to heroin. And you could see here, just focusing on heroin, the graph shows 286% increase in heroin-related overdose deaths, and the percentage of folks addicted to heroin has gone up precipitously. The demographics is very interesting on the left. And what you see here is that there's been a 100% increase amongst females, 50% increase amongst males. The group that seems the most susceptible is the young adult group, 18 to 25. They went up 109%. And we see that at Caron. A majority of our young adult patients, because we have a separate young adult male and separate young adult female units, and we see that the preponderance of those folks are heroin addicts. So it just there's been a real shift in the patients that we see at Caron. And you can see that there is also no significant differences around socioeconomic class or race. In fact, non-Hispanic whites have increased 114%. So that's another variable that is so different than when the heroin post-World War II, Vietnam era heroin was such a problem, which led to methadone maintenance way back when at Rockefeller University. That was relegated to the inner cities. New York City had 75% deaths back then from folks that are folks that were 18 to 35. That led to the studies that gave us methadone maintenance. But that demographic has shifted. Now it's suburban kids, well-educated kids. The kids in our young adult male unit and female unit are graduates, or they're in Ivy League universities, and they're heroin addicts. And it's just not something that we can even wrap our heads around, but it's happening. This exposure to heroin, secondary to prescription opioids, is a real problem. And we as primary care physicians can do something about that. And this is just showing the flattening of opioid analgesics and the overdose death rate and the uptick of heroin. So this is beating a dead horse a little bit, but I just want you to see how heroin is increasing in this country. There's a fantastic book called Dreamland by Sam Quinones. I recommend that you all read it. Dr. Drazis lent me his copy, and I've never given it back to him. Don't tell him, but he's right here. But it's an amazing book that shows the kind of research the cartel does to put heroin on street corners, right down to the street corner. They are way ahead of us in this game. If we think we're going to deal with this on the supply side, it's not going to happen. We have to deal with this on the demand side. So we have to do better at treatment, and we have to reduce the amount of oral opioid analgesics, so decreasing that transition into heroin. So let's just focus in on the Commonwealth. So Pennsylvania is in the wrong quartile here. 3,383 overdose deaths by coroner's report in 2015. Oral opioid analgesics is that blue area, 28%. Illegal drugs, that's primarily heroin and fentanyl, that's 30%. And I want to point out the benzodiazepine piece here, that's 18%. The benzodiazepine epidemic is hidden by the opioid use disorder epidemic. The two are often used concomitantly. If you look at the treatment episode data, which looks at the drugs of choice entering treatment, opioid use disorder and sedative hypnotic anxiolytic use disorder are paired together. And what we find from our patients is that they use benzodiazepines to soften the high with heroin, with the oral opioids that they're using, so that they can have a more enjoyable euphorogenic effect. Because euphoria is increased energy and a sense of well-being. That's a definition of euphoria. So that energy piece they need to soften up. So they're taking benzos. So we have to be responsible about benzos as well. So you can see here, just looking at your county where you work, as you would expect, the big cities like Philadelphia, the collar counties, surrounding counties, Pittsburgh as well, they're the greatest number of deaths, and we haven't gotten better. So this is now 2016, 4,652 overdose deaths in the Commonwealth in 2016, and the numbers are going up, not down. Again, the big city, Philadelphia, the big city, Pittsburgh, surrounding counties are have the most deaths, but it's spread out throughout the Commonwealth. So this is not a city problem. This is a country problem. It's a state problem. So as we've quadrupled the number of prescriptions, so too have we quadrupled the number of deaths over time. And this is just an interesting fact. I'll call your attention to the fact that we are 4.6% of the world's population, yet we use 80% of the world's opioid supply. and 99% of the world's hydrocodone supply. So either the rest of the world is in excruciating pain, maybe because of our current administration, but that's an aside. Or else we're doing something wrong. So obviously it's the latter, not the former. And we have to start thinking differently. And we have some help finally. So the CDC put together guidelines that came out in March of 2016. I'll talk about them in a second. The Surgeon General, the former Surgeon General, Dr. Murthy, who I had the distinct pleasure of spending a day with. He's a wonderful guy, and he wrote the first ever Surgeon General's report on addiction. And his tenets are prevention, education, research, treatment, and recovery supports treating addiction as a chronic disease. I recommend that you read it. It's a snoozer, but it really does help us understand how we're going to get out of this epidemic. And then Dr. Levine, who I've mentioned before. So the CDC guidelines came out, as I said, in March of 2016. And here's just a summary of them. No evidence shows a long-term benefit of opioids in pain and function versus no opioids for chronic pain, with outcomes examined at least a year. So applying acute and subacute tenets to chronic pain not only doesn't work, but it could make things worse. So hyperalgesia, allodynia, secondary to the medications, actually make the chronic pain syndrome worse. And we see that. We have a chronic pain track. Dr. Drazis is in charge of that. He'll talk more about that later on today. But the bottom line is that by simply taking them off the opioids, their pain gets better in a majority of people. Now, we have to do other things to help with their pain, but just doing that helps. Extensive evidence shows harm. So I've talked about that, ad nauseum. And extensive evidence suggests some benefits of non-pharmacologic intervention. So that is acupuncture, medical massage, PT, OT. It's nerve blocks. It's facet injections, epidurals. All these things should be looked at as treatment of chronic pain. And non-opioid pharmacological treatments like SNRIs, for instance, or pregabalin or gabapentin or the tricyclics, these should be looked at first. And that's what we do in our chronic pain track. We give them non-opioid pharmacological treatments and we apply non-pharmacological treatments. And it works. I mean, everyone leaves off opioids and they have sustainable and endurable abstinence from opioids. Now, their pain isn't zero, that's death, right? It's decreased though. And we talk to them about that, we reframe it. Look, this isn't about no pain. It's about dealing with your pain in a different way and reducing the quality and quantity of your pain so that you can live your life. And here's some data around the difference between acute and subacute pain. So in subacute pain, which is defined by pain less than 2 months, you can see those areas of the brain that light up. And when you look at chronic pain, and in this study they looked at it greater than 10 years, and you can see that the medial prefrontal cortex and parts of the amygdala lit up. And these are all about emotions. These are about mood. It's not about pain at that point in time. So what you understand is chronic somatic pain becomes emotional pain. And the medications are then treating that, not actual pain. I mean, there is pain there, but it's not anywhere near the quality of the acute and subacute that started all of this. So how can we treat pain appropriately? We have to understand that it's an unpleasant experience and talk to our patients about that. That this is an unpleasant experience. We're going to teach you how to deal with that unpleasant experience. So we have to look at the biological component. So this is a real entity of pain. So this is nociceptive, neuropathic, central pain syndromes, migraine, cancer pain, fibromyalgia. So we recognize that there is a biological component, that this is real, and then we're going to have to apply other modalities other than opioids to treat it. Pain is psychological in a big way. So we have psychiatric and psychological consults that are done on our patients that are in the chronic pain track. So we understand a little bit more about the mood disturbance that's accompanying the pain. So oftentimes what we find is an increase in distraction, a decreased attention and focus, and sleep disturbance, which we deal with on a real-time basis when they come into us. So we have to address all of those things independently as well. Sociological, and they become homebound, lonely. They have a diminished sense of usefulness because maybe they're on workman's comp or they're on disability and they're not doing the things that they found their value in, and they become dependent on others because of their pain. So we have to start freeing them up to become more autonomous, to get them back into life, so to speak. And then there's a spiritual component, all about suffering. So that sense of isolation, resistance, feeling threatened, wanting to give up. There's a higher degree of completion of suicide in older adults that have chronic pain, older adult males that have chronic pain specifically. So we have to be mindful of that, and we have to really try to deal with the psychological issues and the spiritual issues that underlie the chronic pain. So again, back to the CDC guidelines. So this needs to be a team effort. We are finally training a workforce in addiction medicine, and they need to be tapped to help all the primary care doctors in this room, me included. We have to work as a team. We have to ask them for help. We also have to ask our pain specialist colleagues as well, which I'm sure all of you do, to try to intervene in a non-pharmacological way and help us. We have to deal with this as a team. You can see here, this graph is that we're making progress. So I just want to say that we're making progress, but there's certain counties where we're not making progress. It's actually getting worse. And some of the characteristics in those counties of higher opioid prescribing is that they're in small cities or large towns, higher percentage of white residents, more dentists, more primary care physicians in those areas are prescribing the medications, more people are uninsured or unemployed, more people who have diabetes, arthritis, and other chronic diseases are on disability. Anna Lemke at Stanford, who is the program director at Stanford, who I have a connection with through the fact that I'm the program director at Karen Redding program. She talks about medicating poverty. and really, if you look at the demographics, that's what we're doing here. We are medicating poverty and the pain around that. So just a word about this, because Dr. Drosnes is going to touch on this in a much greater way. But if someone has a fully codified opioid use disorder, you have to talk to them and offer them and hopefully get them medication-assisted treatment. It has to be part of their treatment. And the reason is that MAT has been shown to decrease cravings, decrease relapse risk, and overdose deaths as a result. It reduces harm as well. That was the initial studies at Rockefeller Center with methadone maintenance. There's 3 types of pure agonist, methadone maintenance, partial agonist, buprenorphine, that's Suboxone, and then depot naltrexone, which is Vivitrol. And Mike alluded to the head-to-head study. There was a Norwegian study that came out October 18th that looked at Vivitrol versus buprenorphine maintenance head-to-head. And basically we have choices. There's nuances to both because of the pharmacodynamics and pharmacokinetics, but we have choices. They're equally efficacious and equally safe. So we have to offer choices. And methadone maintenance is one of those choices. You know, I was faculty at Temple for many years, and methadone maintenance saved many lives, and I referred many people to methadone maintenance. So that too is an option. And these shows some of the differences. Dr. Drosnes will go through this a little bit more in his talk. The other thing I just want to say before I end is we need to co-prescribe. I got to meet with Patrice Harris, the former chairwoman of the AMA, and that's one of her big endeavors is to get primary care doctors, to get pain specialists to co-prescribe naloxone. Because if patients are using it in a non-medical way or they're adding other substances to it, naloxone could save their life. Every patient at Caron who has an opioid use disorder leaves with naloxone, either the auto-injector, which is called Evzio, or the intranasal naloxone. And this here, the one that you see there, is an early version that's 2 milligrams. Now it needs to be 4 milligrams because of the synthetic opioids. But every single person at Caron who has an opioid use disorder leaves with the actual product, not a prescription, but the product. And their families, their loved ones, they get intranasal or Evzio. So we make sure that they leave understanding it's a chronic relapsing disease, and that if they do relapse, we want to be able to treat them again, because you can't treat the deceased. So just a plug for my later lecture. Addiction is a chronic disease. I just want to say that, and I'm going to lay that case out in a couple hours, and we'll talk more about that. But in summary, we have to understand it's not a moral failing or lack of willpower. It's a chronic brain disease. We need to treat addiction as a chronic disease. Addiction affects all areas of a person's life, as does chronic pain. It's a family disease, so we have to involve the family in our treatment. MAT needs to be part of that. We need to deal with the mind and the spirit. The A is not silent. It's not medication treatment. It's medication-assisted treatment, so we have to do other things, not just give medication. Treatment works, and the brain heals. At Caron, we have a 77% success rate over a year after treatment. So it works. If you do it right, it works. And recovery is a lifelong process. So here are the references. Thank you very much.